Hello, my name is Professor John Nolan, and I'm very pleased to speak to you about a topic related to nutrition for vision and cognitive health. Over the last 2 decades, research in the area of nutrition for eye care has accelerated, thankfully due to the development of technologies that allow us measure nutrients in real time in the living person. We have been able to understand nutrition of the eye in a much more detailed way than hitherto possible. As part of this educational seminar, what I intend doing is to present to you the background to nutrition, what nutrition is present in the eye, and how this links to diseases such as macular degeneration and visual performance. In addition to doing the background to all of this, I will be looking forward to discussing the methodologies that we have been able to use as part of our clinical trials to allow us test cutting edge and gold standard research questions. We now live in a time where science has informed us in a way that we need to change medical practice in terms of how we use nutrition, how we measure visual performance, and what all of this means for all of our patients. We live in a world where there's a lot more people. We live in a world that is aging. It is the job of healthcare for me to allow us to identify nutritional strategy to protect against age-related diseases such as age-related macular degeneration and Alzheimer's disease and different types of dementias. Our research forms a part of this, and in the coming presentation I hope to teach you new ideas, new methodologies, and new concepts that will allow you work better with your patient using nutrition and day-to-day modifications that can truly make an impact. In terms of disclosures, I must point out that I am employed by a government organisation, and all of my research represents independent research, which is a hypothesis-driven ideas from myself as a principal investigator and my scientific colleagues. I will disclose here, however, that from time to time our participation at international conferences is supported by commercial organisations, but in a way that we retain all of our scientific independence and control. So all of the data that I'm presenting to you today represents independent scientific studies, independent hypotheses, and all of which has been published in high-impact scientific journals. As I said, my name is John Nolan. My background is that I'm a biochemist, and we have been able to secure significant funding to this point to allow us develop a research infrastructure to allow us conduct the studies that I will be speaking to you about today. All of this, of course, is only achievable because we have a multidisciplinary research team that has expertise across disciplines of nutrition, statistics, measurement of vision, and clinical trial management. And it takes such a combination of expertise to allow us conduct the studies and interpret the studies in a way that we hopefully have made it useful for the clinical setting. The slide that I show you here is a very important slide with respect to the story of nutrition of the eye. Here we can see at the back of the eye we have a specialized area known as the macula. Let me remind you that the macula is the part of the eye that's responsible, the part of the retina that's responsible for maximal vision, central vision, and color vision. This is a very specialized tissue, and without a macula we would not be able to appreciate day-to-day visual related qualities such as recognizing a loved one's face, reading a newspaper, driving a motor vehicle, and so on. This is a very important part of our sense. And what was fascinating to me when I began this area of research was to see that in fact we have nutrition that lives in this specialized tissue. And as a biochemist, this was fascinating to me. What was also interesting around this time was that the discovery that these nutrients, which are dietary of origin in other words, if you do not eat fruits and vegetables, you do not have this yellow nutrient pigment in the back of the eye, was located specifically centrally and not in the parafovea. And this indeed was a very important discovery, because it shows us as biochemists that there was a biologically selective duty of this pigment. And again, I point out that this was a dietary pigment. And again, I will point out that all the patients that we see and society have a very varied amount of this pigment. In other words, some people have high pigments, some people have low pigments. We are not born with them, they are dietary of origin, and they're obtained from various foods that we eat. The pigments in question, which we call at the macula the macular pigments, are lutein, zeaxanthin, and mesozeaxanthin. And what we know is that the concentration of mesozeaxanthin, zeaxanthin, and lutein are in equal concentrations, where they collectively form the macular pigment. So in other words, although from diet we may consume more lutein than zeaxanthin and more zeaxanthin than mesozeaxanthin, for some reason the body is programmed to accumulate these pigments in a way that we have equal concentrations at the macula. This pigment typically forms a mountain-shaped profile, and at the center of that mountain we have this unique pigment, this unique carotenoid, which is known as mesozeaxanthin. And a lot of the recent scientific discovery in terms of what we can achieve by optimizing this pigment and optimizing visual performance for our patients is linked to the key role that mesozeaxanthin plays following appropriate intervention. As I said in the previous slide, this pigment forms a typical mountain-shaped profile, and mesozeaxanthin forms the center part of that profile. As we move across the retina with degrees of retinal eccentricity, we see that mesozeaxanthin becomes less concentrated and lutein becomes more concentrated. But again, to remind you, this is a pigment that is dominated and concentrated in the central fovea, in the macula. And once we get to about 6 degrees of retinal eccentricity, we have no macular pigment that's optically detectable. So, for anyone that's interested in optometry, I will say to you that knowing that this pigment functions as an optical filter, I want you to start thinking now about how the unique selective filtration of short wavelength blue light at the macula may have a key role for optics, and this will become clear in my following slides. These carotenoids, which I'm referring to, are plant pigments. They're found in nature. We know that carotenoids, there's about 700 of them that have been identified to date. We know that in a typical Western diet, we consume about 50 carotenoids. We know that in the blood serum, which is the taxi service for delivering these nutrients to the various tissues in the body, that there's about 14 carotenoids. And as already explained, and remarkably, and specifically, we have 3 carotenoids that are concentrated in a very important tissue that is the macula. So again, the importance of this message is that it is a very select process, in that from the 700 plus potential carotenoids in nature, we are programmed to select 3 and place them at this unique tissue that gives us vision. And my job as a principal investigator and as a scientist that's dedicated my life to this was to really figure out why we have this pigment, what is it doing, and how do we optimize it. An important point to make, and a question that I'm typically asked when I give this presentation and when I try and lecture on this, is that, well, why don't we just eat fruits and vegetables to obtain these pigments? And that is a very appropriate question, because as a nutritional scientist, this has to be my starting point. Can we use foods to give us these nutrients? And the reality is, even in a healthy, typical diet, we are not consuming enough of these carotenoids to give us the optimal amount in our blood and subsequently the optimal amount in our macula. The typical American will consume about 1.5 milligrams of lutein and zeaxanthin combined per day. And the reality is we consume very little, if any, mesozeaxanthin from a typical diet. One of the reasons for this, of course, is due to farming. Plants, remember what carotenoids are. These nutrients that live in our eye, they come from the plants that we eat. But we know a lot now about farming and what that does to the quality and the nutrient content of foods. We know that, for example, today we would have to consume nearly 50 bowls of spinach to get the equivalent nutritional value from one bowl of spinach back in 1953. An explanation for this we coin as devolution. What this simply means is that in order to have enough food for society, which we do, we need to optimize the farming techniques. And there are many different farming techniques. However, as soon as we enhance and make it easy for a plant to grow, what we are in fact doing is producing plants, producing spinach, for example, as we see in this slide, that does not have as much carotenoid present in the plant. The explanation for this is because the reason why these powerful nutrients are in the plant in the first place are to help the plant grow. So in other words, these nutrients which are good for important, which are essential for human function and for protecting tissues such as our retina and our brain, are becoming deprived the more and more we farm. So in other words, while as a nutritional scientist I absolutely promote the consumption of high quality nutritious foods such as spinach, peppers, egg yolk and so on, I am worried because I'm saying that the evidence is very clear now that we are absolutely not consuming enough of the important nutrients, and particularly my area of interest is the carotenoids, to give us the protection and the function that we need into our later years. And remember, as said in my previous slides, we are all living longer. So we need to look at nutrition and we need to look at supplementation differently if we are to retain and protect our functions into our later years. And that's why I'm pleased to show you a lovely photograph from the marigold field in Mexico. These plants are known as cempasúchil, the marigold. And the reason why I'm showing you this illustration is because the marigold is an absolutely wonderful source of these carotenoids, which I've been studying for many years now. The orange yellow colors that we see in these plants are due to the presence of the carotenoids, primarily lutein. We also see zeaxanthin, and this is how we obtain mesozeaxanthin as well. And I've actually visited the industries in Mexico that produce the lutein for the supplement industry to understand in total the process. What you can be comforted by is that these are excellent processes which are essentially using the natural plants grown in Mexico to provide lutein for our patients. One of the skills that we have in Waterford, Ireland is to conduct clinical trials. But also we have capacity here to allow us study molecules from the stability and safety all the way through to efficacy. One of the main research programs that I've been conducting over the years has been to study the many commercially available dietary food supplements that are available to the doctor, because what I was fascinated to see was to see the differences in terms of quality and in terms of carotenoid content and from one supplement to the other. So that, I think, is a key learning outcome from today's lecture. If you are making a recommendation for a carotenoid macular pigment supplement, you need to make a recommendation based on a product that has appropriate assessment conducted with respect to the safety of the product, with respect to the stability of the product, and ultimately with how good this product will work for your patient. And the good news is there are many clinical trials now, head-to-head clinical trials, that have been conducted that have identified which formulations or combinations of formulations we should use to give our patients the best results. One important point to make is that primarily for carotenoids, they must be contained within an oil-based formulation. Carotenoids are highly reactive in that if exposed to light or oxygen, they will truly degrade in terms of concentration and very quickly. So fundamentally, if a doctor is making a recommendation for a carotenoid containing product, he or she must do so knowing that this product is appropriately formulated and has been appropriately tested for safety and efficacy. The whole momentum around research in this area started because we wanted to make sure that we protect central vision. We wanted to make sure that patients do not lose central vision and develop diseases such as macular degeneration. But the macular pigments, which I'm speaking about, lutein, zeaxanthin and mesozeaxanthin, what we want to talk about today is their role beyond that of protecting against macular degeneration. I want to show you how optimization and how enrichment of this pigment actually plays a major role in enhancing visual performance and visual function in all your patients. So it's not just about stopping central vision loss. The question is, can we create vision? Can we make vision great again? Can we make vision excellent? And that's really where the data is strong, and the coming slides will hopefully showcase this for you as part of this training module. Let's talk about the properties of these pigments and why would we want to optimize these pigments for our patient. The first thing to remind you about is that the retina, for example, is the tissue in the body that metabolizes more oxygen than any other tissue. We say to patients that doing business with oxygen is the cost of doing business with life. This is a good thing. We need to use oxygen to stay alive. We need to metabolize oxygen. But as we metabolize oxygen in the retina, we produce free radicals. So in other words, this tissue which we require for vision has a lot of unstable free radicals that are produced because of oxygen metabolism. Carotenoids are very important in this regard because carotenoids, because of their chemical structure, can provide an electron to the unstable molecule to make that unstable molecule stable. So it changes a free radical to a stable molecule. And this is a good thing because the carotenoid itself does not become reactive, unlike another cell that may donate an electron. That cell can become reactive. So that's what's unique about these antioxidant carotenoids. And it's very important. Essentially, they're like sunscreen for the eye. And what we know is that a combination of lutein, zeaxanthin and mesozeaxanthin exhibits the best and the most potent antioxidant capacity when compared to lutein on its own, mesozeaxanthin on its own, or zeaxanthin on its own. And you will remember from the early slides where I told you that although we consume differing amounts of these nutrients from our diet, that when we look at the retina and when we look at the concentration of the carotenoids in the retina, we see that they are present in equal concentrations. So this again shows us how biologically programmed and how we've evolved essentially to accumulate these carotenoids to give the retina the absolute best protection by having the combination of these nutrients. And this great work from Paul Bernstein's laboratory in Utah has shown us that the antioxidant potential of the combination is indeed far superior than just having lutein on its own. Now this slide is important because it helps us understand a little bit more regarding the functions of this pigment. And when we look at the possibility of a patient, for example, having no macular pigment versus a patient having macular pigment. And again, I will remind you that it is very possible that some people have no macular pigment. I've measured thousands of people to this point, and a high percentage of people have very little or no macular pigment. Of course, people that have very good diets, or maybe that are supplementing and protect their eyes from sunlight and don't smoke cigarettes, these people can have very high levels of macular pigment. So in other words, it's a nutrient pigment that lives in the macula that is very different from one patient to the next. The scenario on the left hand side, where we see a patient who has no macular pigment, there's two important things happening here. Number one, and as already pointed out, the retina metabolizes more oxygen and produces free radicals than any other tissue in the body. What happens here, unfortunately, is that our cells of vision, our photoreceptors, are degraded by the insult of these free radicals. And if our antioxidant defense system is suboptimal, and this happens of course with age, what happens is we end up destroying the cells that we otherwise require for vision, and here we see this diseases such as macular degeneration. The other thing that this macula without macular pigment is vulnerable and exposed to is the insult of blue light. Now, I would like to remind you that when we look at the light spectrum, we understand that ultraviolet light on the whole does not reach the retina because the front of the eye, the lens and the cornea, is designed to filter this very high energy UV light. However, in order for us to appreciate the colours of the rainbow in vision, the visible light spectrum is indeed incident on the retina. And short wavelength, high energy blue light produces free radicals. So it's another reason why we produce free radicals in the retina. But this is also a problem beyond that of destroying the cells of vision for visual performance, because short wavelength, high energy blue light is scattered, and scattering inside the eye results with veiling luminance and suboptimal visual function. In other words, even in a healthy eye that has suboptimal macular pigment levels, the blue light scattering is absolutely going to be problematic in terms of their visual experience. So the counterpoint is true, that if we were to optimize the pigment, and this is the whole idea here, that we can not only protect the eye against free radical damage, oxidative stress and cell death, we can actually enhance visual performance. And this has been a focused and a key area of research that we've been looking at over the last number of years. So the opportunity then is seen on the right hand side, and this is where we have a patient where we, with appropriate nutritional supplementation, optimize the pigment. Two things happen. In this scenario, the free radicals that are produced can be neutralized, can be quenched, can be managed by the antioxidant capacity of the yellow macular pigment. But also, and wonderfully uniquely, is how this yellow macular pigment filters short wavelength blue light at the macula only. And this is really good for visual performance because it reduces light scatter, of course, because this is all happening pre-receptorial. But also it allows blue light hit the parafovea. And this is really important for optics and for optometry, because we know that the rods which live in the parafovea require blue light for night vision, for example, and also our circadian rhythm, our mood, everything is affected by blue light. So the solution is not just to use spectacles or intraocular lenses that abrasively remove total blue light from the retina. If that was the case, our retina would have evolved to filter light across the entire retina with these pigments, but it hasn't. And that is what makes macular pigment unique, and that is why supplementation is the only way to achieve the desired outcome in terms of exquisite and unique optics and filtration and antioxidant capacity. And this point is borne out in this slide, and I would like to point out it's important that we understand that the measurement of this pigment is also now possible, but also how we measure visual functions is key to our understanding of this. If we look at this slide and we see that on the left hand side we have a scenario where the patient scores good in visual acuities, on the right hand side this patient will also score fine in visual acuities. But if we measure contrast sensitivity, we see very different outcomes. We see that the patient on the right hand side that has a lot of light scatter, and this can happen with cataract for example, their contrast sensitivity is very, very low indeed. And one of the learning outcomes that I would like from my education lecture here today is to say that I truly believe that the eye care communities across the world that have an interest in their patient and their vision need to look beyond that of best corrected visual acuity, which, while it's an important measure of visual performance, doesn't really correlate very well with how the patient feels. So it is important that when we're doing our outcome measurements that we understand the differences between assessments such as acuities, contrast sensitivities, and simply, and I'll be bringing this up again later, what we know with certainty is that how well the patient feels with respect to their vision and their visual performance and their visual function correlates really, really well with measurements of contrast sensitivity. But it doesn't correlate well with measurements of best corrected visual acuity. So I think this is a game changer for eye care, for optometry and ophthalmology, that if we want to understand vision, if we want to understand diseases and how diseases affect vision, we really need to do better than rely on best corrected visual acuities. So now I've gone through the background, I've gone through the discussion of the macular pigments, why we've been studying them, how selective they are for the macula, their properties, their antioxidant and their optical properties, which are clearly important for the macula. I've hopefully stimulated the idea that optimization of these pigments is much more important than just that for macular degeneration, and in fact that this is a lifestyle necessity that we need to implement to give our patients best and safest vision into their latest years. And this, I believe, is achieved uniquely via the exquisite optical properties of the macular pigments. But of course, any eye care professional should and must look at science that is evidence-based. They should and must operate a research-based evidence approach. So I would like now to summarize what I believe are some of the gold standard studies that have been conducted from my centre, but indeed from other centres, and with particular emphasis to the AREDS study and what I feel we've learned from the AREDS study, and how this level 1 double-blind placebo-controlled series of clinical trials has really changed how we should use nutrition within the eye care community. And we are going to begin with the age-related eye disease study. The original AREDS study provided proof of concept. In a large sample, there was nearly 5,000 patients. It was a multi-centred, randomised, double-blind, placebo-controlled clinical trial. The interventions here were vitamin C, vitamin E, beta-carotene, high zinc and copper. There was no macular carotenoids in the original AREDS study. There was a follow-up here of 5 years, and this was a research program funded by the National Eye Institute, the NEI. The groups under investigation here were a placebo group, an antioxidant group, a zinc group, and a combination of antioxidant and zinc. This original AREDS study, as I said, provided proof of concept that optimization of nutrition via a combination of antioxidants and zinc exhibited a 25% risk reduction in terms of progressing from intermediate to advanced age-related macular degeneration. And this was an important discovery for ophthalmology because it was the first time that a level 1 clinical trial of this nature had shown an intervention that could impact positively for this terrible disease, age-related macular degeneration. However, as the methodologies and the data from other trials became available, there was an understanding and a realization from the NEI and indeed from the principal investigators on that study that there was an oversight in terms of not having used the macular carotenoids. And oversight may be an inappropriate description of that because maybe they were not, my understanding is they were not commercially available at that time or available for the trial. Nonetheless, the acceptance that the important nutrients in the eye were those which we've been speaking about today, lutein and zeaxanthin, should be used in a similar trial, and therefore the AREDS 2 study was designed and which was published in 2013. Remember, these trials were designed where the primary outcome measure was disease progression. So did the disease get worse? Did it progress? Yes or no? And in order to do such a trial, one needs to have a large number of patients and it needs to have appropriate follow-up time. Again, the AREDS 2 trial was multi-centered, it was randomized. The primary outcome measure was progression to advanced AMD, and they had many other secondary outcome measures, but unfortunately they did not do measurements of macular pigment, and they did not do, in my view, appropriate measurements of visual performance, in that they just looked at visual acuities and not contrast, as I've previously discussed as being important. I want to draw your attention to this slide because this represents, in my view, one of the challenges in terms of the AREDS 2 trial and what we should take from it. I have put an asterisk there on the control simply because in the AREDS 2 study there was no true placebo group because the control group were provided as standard of care the original AREDS 1 formula. The other group had that same formula but plus lutein and zeaxanthin, and the group number 3 had that same formula but plus DHA and EPA, and then the final group had lutein and zeaxanthin plus DHA and EPA on top of the original AREDS 1 formula. So that is the point. Everybody in the AREDS 2 study was receiving an antioxidant intervention rather that had been shown by the original AREDS study to have a benefit. So the research question here was not if we supplement with these particular nutrients, do we have benefit for AMD? Essentially, it was if we add extra nutrients on top of that, do we get a benefit for patients with age-related macular degeneration, where the primary outcome measure, as explained, was disease progression. The results from the AREDS 2 study are seen here, and that was, although the primary paper, the first paper that came out, showed us that although the addition of lutein and zeaxanthin did have a benefit, this did not reach statistical significance. However, when we looked at the secondary outcome paper, which was also published around the same time, this is where we really start to learn about the importance of the AREDS 2 investigation. What we see on this slide is that if we look at the hazard ratio data here, essentially anything to the left of the center line represents a positive finding, anything that doesn't cross the line is not statistically significant, and anything to the right represents a kind of a negative finding in terms of the study outcomes. And what you can clearly see here is that there was a significant benefit of those that got lutein and zeaxanthin versus those that did not get lutein and zeaxanthin. And taking that research question on the whole, we see a 10% additional reduction in the risk of progression to advanced AMD when lutein and zeaxanthin were added to the intervention. So that this was really, I suppose, good news for the macular pigment world, because it kind of proved what we had all been saying for nearly 2 decades about the importance of these nutrients. A very interesting piece of data from this trial is seen in this slide, and that is when you look at patients in the AREDS 2 investigation that had lowest dietary behavior, so they were in that lowest quintile of dietary performance, they had an enormous benefit. They had an additional 26% reduction in terms of progression. Now, what I want to point out here is actually very important learning outcome from this slide and from this study, and that is the lowest quintile of dietary behavior actually is representative of the general population of the United States of America, because the other quintiles were people, as I've explained, that this population had been well supplemented and well nourished and well informed for many years about the AREDS study, so not very representative of what's normal. But looking at the lowest quintile, that's different. These were representative of what's normal, and it was here that the fantastic result was seen, and the importance of lutein and zeaxanthin was highlighted, essentially making it now the standard of care for ophthalmology. And that's seen here. This is an actual recommendation directly from the NIH, and Dr. Emily Chu allowed me to use her slides for this educational lecture today. And what we see here is that the recommendation, the standard of care with respect to the AREDS formula, is vitamin E, vitamin C. Beta carotene is no longer. This has been replaced by the lutein and zeaxanthin, the macular pigments. They still have zinc at 80 milligrams. I want to discuss that in the next slide. Copper, and there's a lot of debate around omega, but in terms of the NIH recommendation, omega-3 fatty acids, DHA and EPA, are no longer part of that recommendation. Now, as you see here, the zinc they have left in at 80 milligrams. I want to make some points about zinc, because while I'm not a zinc expert, I absolutely advise that caution is taken when a healthcare professional is making a recommendation of a food supplement containing very high amounts of zinc. And the reason for this is seen in this excellent paper, which shows us clearly about the potential issues of having excess zinc. And study of the data that's available to us shows us that we should not go in the upper limits of 40 milligrams per day of zinc. It is important antioxidant. It is a powerful antioxidant. The AREDS study has shown its benefits, but the AREDS study itself also showed absolutely categorically no difference between patients taking very high zinc and versus those taking low zinc. So I question and I query the rationale as to why the NIH remain to keep zinc as in the 80 milligrams recommendation, and I would draw caution to such a recommendation. And essentially what I say with confidence is, if a healthcare professional wants to make a recommendation that is an AREDS 2 based, I applaud that, but I say do so and make sure that it has low zinc. That's very important. I now want to take you to show you some of the more focused clinical trials in macular pigment, and this is data from the Nutrition Research Centre in Ireland. This is the headquarters where I work and the centre that I manage, and within this facility we have capacity to conduct clinical trial, project management, measurements of visual function. We have a whole visual function suite, we have a cognitive function suite, we have our own analytical chemistry laboratories where we do carotenoid assessment of blood, and everything up to the dissemination and publications. And we put a lot of effort to try and make sure that the work that we've conducted, that's supported by government and in many cases by the taxpayer, gets published in journals that are useful for healthcare professionals. And we're pleased to say that we believe that we've influenced greatly healthcare professionals across the world based on this very good science that we've been able to conduct. And this is, of course, I made reference to the evidence base and the scientific base that we should be trying to achieve. We now are approaching 100 peer-reviewed scientific publications relating to nutrition for the eye, nutrition for cognitive health, and everything from how we measure these pigments all the way through to our level 1 clinical trials. I want to show you some of the methodologies that we use that allow us assess and quantify and study these nutrients at a very sensitive level. We put a lot of effort in our laboratory to be able to understand compliance to an active intervention. So in other words, if I am to give a patient as part of a clinical trial a carotenoid intervention, we draw blood samples at the study visits, and we have developed our own methodologies that allows us, and for the first time, separate the nutrients of interest, lutein, zeaxanthin and mesozeaxanthin. And this is achieved using biochemistry, analytical technologies, which we call high-performance liquid chromatography. It is essentially just a separation science technique whereby the analytical chemists at our research facility can take a blood sample or can take a supplement or can take a tissue, and what we can do is we can put it through an extraction technique that separates the carotenoids that we're interested in, and then we run them on a system, as I said, called a high-performance liquid chromatography. And this is a separation science that splits these molecules, and if you split them successfully, which we've been able to do, you see here that we are able to get this is an example of a blood sample, and you can see here the many different peaks of carotenoids that are present in human blood. And this just looks like squiggly lines, but each of those peaks have been identified as molecules, carotenoids that we have an interest in studying. And what we see here goes back to one of my first slides of this education lecture, and that is that the actual concentration within the bloods, i.e. the size of these peaks, is quite small on average across our populations. And this confirms my point that we are eating foods that are nutrient deficient. And here's why I know this, because here's what happens when you supplement. If you take a supplement, the supplement used in this experiment was a supplement called Macular. What we saw was that we were able to achieve a 600% response in lutein and also in the zeaxanthin molecules, mesozeaxanthin and zeaxanthin. So to assess these, and we can do now with exact science, so we're very confident around this, we're able to study these molecules and understand them. And this is important, of course, also when we look at how our analysis of how safe these compounds are, being able to split them and measure them and work with them has allowed us to arrive in that scenario. And of course, it's also important that we're able to measure the macular pigments in the living subject. And I've used many technologies. There's subjective tests available and objective physical tests that are available. And the majority of these tests are research-based assessment tools. My message to anyone that's interested in measuring macular pigment in the clinic setting is that while there's developments in place with respect to the Heidelberg Spectralis, for example, that will allow the measurement of macular pigment in real time, providing very nice imagery. And we've also used densitometer devices from Brown University developed by Professor Billy Wotton with success. Really, the measurement of macular pigment, in my view, in the clinic setting is very difficult and problematic to this point. And I would draw a lot of caution to this, because I know that there are many commercially available technologies being promoted to measure macular pigment, where they claim they can do this quickly and with accuracy and with validity. But I'm very confident to say, as part of this education, that these technologies have lots of concerns and have lots of validation issues and reliability issues, and accuracy issues. And I fear that some optometrists that are using such technologies that have been promoted to them are probably getting inaccurate data on their patients. So while I support the measurement of macular pigment in the clinic setting, and if we are using flicker devices, for example, let me say that it's absolutely essential to perform a peripheral measurement, a reference point essentially. I feel that the clinic technologies that are available to now are not ready and do not give us the total amount of data that we need to understand the macular pigments in our patients. So I would draw caution to the measurement of macular pigment in the clinic setting, and I look forward to seeing technologies such as the Heidelberg Spectralis being made available to the clinic setting in a feasible way, whereby doctors can get images of patients' macular pigment that they can rely on, as opposed to technologies that are very subjective and very influenced by peripheral measurements, which in some cases are not even conducted. So the point of that is to be cautious about the measurement, but also to say that in the research setting, of course, with the luxury of time and with the luxury of investment that we've been able to put into these technologies, we have been able to achieve a lot in terms of the measurement. So we can do it now in everyone from the young sports person up to people with Alzheimer's disease. In terms of the Heidelberg Spectralis, using the autofluorescence technique, this has been very successful within our research facility, and essentially using an image similar to taking a retinal image. We use autofluorescence, and we see here on the left hand side a scenario where there is a dark area across the macula. This is because with the blue laser, the filtration of light, blue light, by the macular pigment results with a depressed autofluorescence, whereas when you have a green laser, you see that you don't get that depressed autofluorescence because the macular pigment does not absorb the green. So if you do a small movie, you can digitally subtract one from the other, and you get a beautiful image of the macular pigment. And this is, remember I said the pigment has typically a mountain shaped profile. This here represents half of that mountain. And the full image gives us so much more data than just measuring at one eccentricity, which a lot of these flicker technologies do. So I would like to draw attention to that. And this is seen quite nicely here, in fact, because if you look at the scenario on the left hand side and the right hand side, and if we were to use a flicker technology that's measuring at the very center, both these patients have the very same central macular pigment score, but they have a very different macular pigment volume. And in the absence of measuring the entire volume, the entire image, you're really not understanding, in my view, the macular pigment, the total macular pigment volume. So that's the measurement of the macular pigment. I now want to speak about the importance once again of how we assess the main outcomes from these trials, and that is looking at the visual function measurements beyond that of best corrected visual acuity. And the point that I've already made is that contrast sensitivity is a very important measurement in this regard. The reality is that we still use, in the international language of vision, is still best corrected visual acuity, which represents an assessment of vision at 100% contrast. But we all know that nothing in life has 100% contrast. So it's not for me, it's not a very true and accurate reflection of the patient's visual performance. And that's why assessing contrast sensitivity is much more useful in terms of giving us data about visual performance for our patients, because it correlates, as I said, with how your patient feels, and fundamentally that's important. So contrast sensitivity is important. And in our laboratories we also have technologies which we've been using now for many years, and primarily technology developed by City University Professor John Barber, that allows us to look at global visual performance. And this technology was originally developed for the aviation industry. So when we conduct clinical trials here, we're not just looking at visual acuities, we're looking at contrast thresholds, we're looking at photostress recoveries, we're looking at cone sensitivity, rod sensitivity, we're looking at daytime vision, we're looking at nighttime vision. So we look at the totality of the vision, and that's very important when doing clinical trials trying to optimize lifestyle or nutrition for vision and for human function. I now want to take you on a small whistle tour of what I believe are some of the main research publications that have evolved our knowledge and that have led to the development of nutritional strategies that should be used across the world. And in the earlier studies, fundamentally what we discovered was that if you look at patients, or individuals rather, not patients, so people that have no disease, and if you take 1,000 people like we did in Ireland, and if you then categorise them based on their risk factors for macular degeneration, so in other words, if you take your cigarette smokers, or if you take your people who have a confirmed family history of macular degeneration, or if you just look at the elderly section of the population, and again remember, all healthy, what you see is that individuals at greater risk of macular degeneration have significantly lower macular pigment than those who do not have such risk. And this is seen decades before these people will develop the condition. So in other words, a 40-year-old male that has a family history and smokes cigarettes, and whose genetics say that they're likely to get macular degeneration, that individual at that time point will have much less macular pigment than a 40-year-old male without such characteristics. So this kind of closed the loop in terms of our knowledge and what we know about, the pigment before, and the potential role of the pigment before any of these diseases present. One of the most important discoveries, I believe, from our centre was that when you look at the profiles of pigment, and as the technology developed, we were able to not just measure central macular pigment, we were able to measure the total profile. We discovered that about 12% of the population had a dip in their macular pigment. So they didn't have what was typically believed as the normal shaped mountain, peaked mountain. They had like a more volcano shape. And what was really interesting was that these people were in fact higher risk of macular degeneration. So again, they had healthy maculas, they had no disease. But when we measured their pigments, we saw they had dips, which we coined as a central dip in their macular pigment. We hypothesized at this stage that this was due to a deficiency in mesozeaxanthin. And the reason why this was a deficiency in mesozeaxanthin was because when we looked at the anatomy studies, we see that mesozeaxanthin appears to be concentrated at the very center of the macular pigment. So we wanted to test this idea in the context of a clinical trial, and we did that. And what we discovered was fascinating. If we look at the top right hand slide, what we see here is that these patients, these volunteers, these subjects that had central dips in their macular pigment, when we gave them a or lutein only, they left the experiment with a dip. So in other words, we could not fix their macular pigment profile. But when we gave them mesozeaxanthin, and if we look at the bottom slide to see this, high concentrations of mesozeaxanthin, we see that we were able to enrich their central macular pigment, so essentially fix the problem. But the best result was seen when we gave them a combination of lutein, zeaxanthin and mesozeaxanthin. And the formula used in this experiment was a formula that's commercially available known as Macuhealth. We saw that we got a central enrichment in their macular pigment, but most importantly, a total enrichment across the entire profile. So if the objective of the exercise is to enrich macular pigment via nutritional supplementation, we've now discovered the best way to achieve this, and that is with a combination of lutein, zeaxanthin and mesozeaxanthin. And there's been now many head-to-head clinical trials testing this research question further, because the discovery around the importance of mesozeaxanthin needed to be tested in total, and that is looking at what happens in serum, is there competition, all the way through to how well does it impact on macular pigment and visual function. And all of this led into the development of the Crest clinical trials, because all of these 8 to 10 head-to-head clinical trials previous, comparing formulations with mesozeaxanthin to formulations lacking mesozeaxanthin, really truly showed that the addition of mesozeaxanthin was very important. And because of all this, let's call it exploratory data, we were able to go to the European government and say, we have a research finding here that we believe is very important for a disease called macular degeneration, but also in terms of making the retina healthier with macular pigments for the general population. And the claim that we had with this research question was that we could optimize these pigments and enrich them in a way that we could create better visual performance for all patients now and for society now, and in also achieving longevity of nutrition of the eye and visual performance in the eye, and preventing essentially diseases such as macular degeneration. So essentially the big research grant which we were successful in winning, over 1.5 million in 2011, was funded by the European Research Council. And this project was launched by the Prime Minister of Ireland at our research facility. Essentially we had two groups that we were interested in studying. These two groups, one group was healthy normal individuals. We conducted a double-blind placebo-controlled trial where we compared Macuhealth, that was that 10-10-2 formula, to a placebo. This was a 12-month intervention, and remember, this was in a healthy population, so no retinal disease, very healthy indeed. The second research question was for patients with macular degeneration, and I'm going to discuss both of these trials now. So we compared, in the context of a placebo-controlled double-blind intervention study, a formula containing 10 milligrams of lutein, 10 milligrams of mesozeaxanthin and 2 milligrams of zeaxanthin. That's Macuhealth versus placebo. We had a data safety and monitoring committee in place, and we had an international collaborative team that were involved in the design and the protocol for this gold standard clinical trial. In terms of screening, I'm going to show you the age-related macular degeneration results now. We assessed over 400 people. We wanted to make sure that patients recruited into this trial just had age-related macular degeneration and no other pathologies. So, when patients were newly diagnosed by their ophthalmologist or optometrist, they then had to come to our centre for another assessment, the screening assessment, and then we sent the imagery to the University of Wisconsin for retinal grading and to Moorfields Eye Hospital in London for grading. And only when the assessment of the healthcare professional, the clinical assessment, matched that of the grading centre, were patients recruited into our trial. The patients had to be 18 years or older for the general recruitment. For the normal trial, they had to have low central macular pigment and no ocular pathology. Here we see examples of macular pigment profiles in subjects with low macular pigment. So again, to summarize, I'm showing you now the data from the trial one, which was in that young healthy population. The primary outcome measure was contrast sensitivity at 6 cycles per degree, and we had many secondary outcome measures including visual acuity, contrast sensitivity, macular pigment, glare disability, photostress recovery, light scatter, cognitive function, and of course serum carotenoid assessment also. For trial 1 in the healthy population with low macular pigment, we assessed them at baseline, 3, 6 and 12 months. A typical study visit lasted approximately 2.5 hours, 2 hours and 30 minutes. We finished recruitment for this trial on 3rd of June 2014, and compliance was managed throughout the study. The baseline findings from this investigation showed us, because of the very strict double-blind placebo-controlled trial nature, it showed us that the active group was highly comparable to the placebo group. So therefore, the subjects that were on the active intervention were identical in every way to that of the placebo group. The results are presented here and were really fascinating. Here we see that the carotenoids of interest, lutein, zeaxanthin and mesozeaxanthin, showed a wonderful increase in the active group, whereas there was no change in the placebo group in these interventions. This was the largest type of response that we had seen in a clinical trial when we compared it to other clinical trials that we conducted here and indeed across the world. This slide shows us the change that we identified in macular pigment over time in this placebo-controlled trial. And again, the placebo group exhibited a very steady baseline, which shows good validity around the measurements that we're doing. But we see a wonderful improvement, which gets better with time, in subjects that were supplemented with the MacuHealth intervention. This is the first study in published science that shows us an intervention that 100% of patients exhibited a meaningful response. So we now have an intervention that if we give to a subject or to a patient, we know from this trial that if they comply to that intervention, that they will absolutely achieve the desired outcome of an improvement in their macular pigment. Here you can see individual data showing change over time, and we can see that on average you get about a 100% improvement by 12 months in terms of the macular pigment profile. So in other words, there's a lot more antioxidant capacity and there's a lot more blue light filtration capacity. In terms of the primary outcome measure, which was contrast sensitivity, we see here that in the healthy subject that had best refraction at the beginning, when the only thing we changed was their macular pigment, we improved their contrast sensitivity by about 15 to 20%. So in other words, we've taken what people consider as normal, good vision, and we've made it better. So the primary outcome measure was achieved in this clinical trial. In addition, secondary outcomes have been achieved, and this is published in subsequent work. All of this data and the primary report, report 1, can be seen published in a paper in Investigative Ophthalmology and Visual Sciences. And this is all available on my website, ProfessorJohnNolan.org, for those who would like to get the full paper. The impact of this, of course, for society and for clinical practice, I believe, must now extend beyond that of the patient with macular degeneration. This data is conclusive in that regard. And the opportunity is that we can create a world that has better vision and a world that has safer performance. And it has implications for driving, which is even more important at night time. It has implications for just everybody in terms of, their wellness and the importance of vision for wellness and mindfulness. So it's about all of these patients that can come into a practice. This is what macular pigment optimization can impact upon. And of course, This becomes very important when we look at select disciplines such as military, the police force, the fire services, etc. Subtle differences in performance across these disciplines has a major impact on performance, safety, health and wellness. And again, we've seen, and there's a lot of work now done in terms of using these nutrient pigments for sports performance and the sports world, and centres across the world now have shown in very good studies the impact of macular pigment augmentation for the world of sports and sports performance, and this has now been used with great success in this regard. So the mindset has to be different here. We're not talking about nutritional strategy for the old or for people with diseases. We're actually talking about everybody else. That's what's really cool about this. And as I said, baseball is a very good example, because not only is it the impact of this pigment on visual performance, it's the cognitive elements, which I'll come to, are very exciting here as well. That takes us to the second trial for Crest AMD, and as I explained previously, we went on a very strict recruitment campaign for the AMD population, and we screened over 276 people for this trial. We randomized 121. I want to point out here that the primary outcome measure here was not disease, was not morphology, but rather it was visual performance, and our studies were powered to do this. We wanted to have a very clean sample where people had never supplemented and where the disease was only early macular degeneration. So that's why our eligibility criteria, we see no retinal pathology, we see no previous consumption of supplements containing the macular carotenoids, and we see that it must have been exquisite in terms of the disease categorization. We put a lot of effort into recruiting and working with local media, hospitals across the Republic of Ireland for this trial. Again, the primary outcome measure was contrast sensitivity at 6 cycles per degree, and many secondary outcome measures also. We put a lot of effort into ensuring compliance and safety around this trial, and all this data is now available within the primary publication from this work. The baseline findings again show us that the two groups were comparable with respect to age, body mass index, smoking habits and so on. The baseline findings are seen here in terms of all the measurements of visual performance that we did, again with a keen emphasis on contrast sensitivity. The punchline and the main discovery from this work was that when you optimize macular pigment in a patient with early age-related macular degeneration, we conducted 32 tests of vision, everything from glare sensitivity, contrast sensitivity, reading speed, and so on. What we discovered was that 24 of 32 tests of visual function actually got significantly better. When we looked at morphology, we see that, remarkably, no patients that were given the 3 carotenoid intervention actually progressed in terms of the morphology, in terms of the disease status. And when we go back to our visual function outcomes, what I can tell you is that looking at what was clinically meaningful, we see that the best results were seen when the combination of the 3 carotenoids were used, again true to our earlier work, showing that mesozeaxanthin, lutein and zeaxanthin in a combination are very, very important to get best outcomes. Here you can see the trend lines similar to what we'd seen in the normal population for improvements in lutein, zeaxanthin, mesozeaxanthin. And also we show that all the patients that were given the 3 carotenoid intervention exhibited a wonderful result in terms of their macular pigment improvements, and the longer you supplement, the better the outcome. So in other words, the data was stronger at 24 months than it was at 12 months. So this is a lifestyle change, this is a compliance change in terms of what normally happens. We see the shifts in the contrast sensitivity curve here. Essentially, what we've been able to do is take a patient with early macular degeneration, and what normally happens to that patient is their vision gets worse and deteriorates. We have now sent the trend line in the absolute opposite direction. We have given them vision that they didn't have before the carotenoid intervention. Photostress recovery was a very strong finding as well, and we see here on average an improvement in photostress recovery by about 6 seconds. This was confirmed by our retinal stray light data also. So the main conclusion from this is that in terms of macular pigment augmentation and in terms of visual improvements, when you use a combination of lutein, zeaxanthin and mesozeaxanthin plus the co-nutrients seen in AREDS, you get a really wonderful outcome in terms of visual performance improvements. And for me, this now should represent the standard of care for what we do in ophthalmology and optometry. This work, of course, is published in also in investigative ophthalmology and visual sciences. So I suggest that that paper is sourced and used as a strong reference for recommendations. The global conclusion I have from all the work that we've done to this point with respect to optometry and ophthalmology is that we know that some important points. We now know that the carotenoids, lutein, zeaxanthin, are the main and truly source of the macular pigments. We know that these are very safe nutrients and that there's no contraindications with consumption of these nutrients for our patients. We know that when you use the 3 carotenoids that you will get 100% of your patients to respond. And we know that the visual function outputs that we get are best when the 3 carotenoids are used. And if you think back to the educational slides that we had today on the antioxidant capacity and how that's better when the 3 are present, the light filtering capacity, how that's better when the 3 carotenoids are present, this all now makes sense in terms of what the clinical data has shown. Essentially, we have proven the hypothesis around this research question. An interesting meta-analysis shows this very nicely in terms of macular pigment response and the best way to achieve macular pigment improvements in normal healthy subjects and in patients with AMD. This meta-analysis concludes that a combination of lutein, zeaxanthin and mesozeaxanthin is the best way to achieve this. The final section of my lecture today is to talk about beyond that of the retina, because I truly feel that we now have a standard of care for optometry and eye care, and I truly feel that it's really important now that the eye care community embrace this and use this for patient benefit. And I absolutely believe that a reluctance to do this and an avoidance of an understanding of what the literature says means that we're not doing the best we can by our patient. So I'm saying quite clearly here that it's not okay anymore for us not to understand the macular pigments, the role of the macular pigments, and how these can help vision and protect vision for all of our patients. And also for the future, my research will focus on how these nutrients impact on the cognitive world. And we know that not only are the macular pigments found in our retina, recent studies have shown very nice correlations between the amount of these pigments in the retina and that of certain parts of the human brain. And this is important because we can measure this pigment in the living person, and knowing that it correlates with the pigment in the brain is a very important discovery. And essentially the measurement of macular pigment can function as a biomarker for brain nutrition. And we've had a couple of important discoveries along this. We know that these nutrients live within the synapses of the human brain, and essentially just like at the retina, and remember we're essentially talking about the central nervous system here, the retina has an important role for these carotenoids in terms of their antioxidant and optical properties and also anti-inflammatory. This is absolutely vital for brain, because not only is the antioxidant role important, the anti-inflammatory capacity of these pigments is really important, but it's actually their structural integrity that they give to the synapses and to the components of the brain. Nutrient forms the structure and supports the structure of the brain. And I truly believe that this is one of the key functions of nutrition for the brain, and the identification that these nutrients are present in the brain is very important. As I said, they live within the gap junctions. And the discoveries to this point from our centre and others across the world are, and I'll summarise them quickly, if you take nearly 5,000 people, and we've done this, and if you measure their macular pigment, and we've done this, and if you measure their cognitive performance, we see absolutely that those with high good macular pigment have much better cognitive performance than those with low macular pigment. We also know that this is the case if you look at patients with macular degeneration and measure cognitive performance. We see that those with higher pigment have better performance and, of course, better vision, which we now know. We were the first in the world to discover that patients with Alzheimer's disease are actually deficient in macular pigment, and primarily due to the fact that they are not eating any of these foods. And once the disease gets worse, we know Alzheimer's patients, they find it difficult to eat these type of foods. The net result is really bad pigments, really low pigments rather, and suboptimal visual performance. So this is a vicious cycle for them, in that they're not eating, they have low pigment, and they have really bad vision as a consequence. And we conducted a clinical trial that showed this, but also that showed that if we supplement them, and again we used the MacuHealth intervention here, we were able to improve their pigment, and we were able to improve their contrast sensitivity measurements significantly in this population, this vulnerable population, patients with Alzheimer's disease. And we also looked at this as part of the Crest study. And we wanted, again now, I'm talking about the young, healthy population here as part of the Crest study. And remember, we've shown that if you take this young population, healthy population, with low macular pigment but healthy retinas, and if we augment the pigment, we can achieve very good results in terms of their vision. This secondary paper had a look at the cognitive function elements, and this is work that's just newly published. And what we discovered was, we looked at all cognitive domains of memory, executive function, verbal fluency, attention tasks, and so on. We performed very strict statistical analysis on this sample. We had, again, the active and the placebo group, which were highly comparable at baseline. We see here they were also highly comparable with all the assessments of memory and cognitive functions that we performed. And the results were quite striking. When we look at the time group interaction effects, so the question here was, over time, was there an improvement in cognitive outcomes, memory, reaction time, that were different between the active and the placebo groups? And what we found was that absolutely yes. We were able to enhance memory in the normal, young, healthy person in a clinically meaningful way. So this is a game changer, really, because, again, proving that we are suboptimal in these nutrients. And what we're now showing is that this not only has an impact on the health of our retina, but it impacts greatly on our cognitive abilities and our attention abilities. So if I take these healthy people, and if I change one thing, and that is their macular pigment, in this scenario here, I see that I can make them enhance their memory performance very well. Here you can see, for example, errors with memory. Absolutely. With the active intervention, we create a scenario that they perform, and compared to the placebo group, much less errors in memory when they conducted the memory test, and this was achieved at 12 months of the intervention. Also, when we look at the correlations, we see some striking relationships between the magnitude of response and what that actually means for the patient in terms of their memory improvements. Here you can see here again the PAL assessment, and the greater the response in macular pigment, the greater the improvements in memory in these patients. And these are just some other examples. To see this cross-sectionally is very important. So this data is newly published, and actually just been informed today, has been identified as a major paper for the Journal of Alzheimer's Disease, and a newsworthy paper, and the journal are now going to promote the findings of this because of the impact that this has. So I'm very pleased as a PI that this paper has been selected by the Journal of Alzheimer's Disease as their most noteworthy paper for discussion. And this should give us a lot of confidence if we're making recommendations about supplementation, that not only are we doing good for visual performance, but it's having a direct impact on the cognitive and the mindfulness of our patients as well. And we're continuing to investigate this, and we're now in the middle of investigations looking at mild cognitive impairment. And just like what we've been able to achieve with age-related macular degeneration, if we are to enhance these carotenoids and co-nutrients in the brain in those maybe at early stages of Alzheimer's disease, can we have a positive impact? So my general conclusion to end my educational lecture today is to try and say to you that let's not think any more about nutrition of the eye just for a disease or when a disease is present and we don't know what to do. The evidence is very clear that this well-tested 10-10-2 intervention with mesozeaxanthin, lutein and zeaxanthin is now proven to show visual function benefits for all of your patients, and this has implications for all of these disciplines that we've been discussing, and indeed, as I said, is now being used with success, for example, in sports and athletes and in military. So that's important, and I recommend a focused carotenoid-only intervention to do that. The 3 carotenoids are what's required for that. When we look at age-related macular degeneration and how we should, as healthcare and eye care professionals, try and work with our patients to give them the best outcomes, it is absolutely clear that if your research question here is visual function, that again the combination of lutein zeaxanthin and mesozeaxanthin is the best way to achieve that. If as a doctor you want to make a recommendation that is AREDS 2 driven, again I agree with that, because this is the standard of care, but I would suggest that you absolutely use a formula that has low zinc and that has mesozeaxanthin. And the formulation we tested in our clinical trials was a supplement that was commercially available called MacuHealth Plus. That had low zinc and it was fortified with mesozeaxanthin. That was shown to be very safe for these patients, and that was shown to give fantastic results in terms of macular pigment and visual function outcomes. And to finally say, this has been a fantastic scientific evolution within our community, thankfully in the last decade primarily, because of the establishment of technologies that have allowed us measure in real time the molecules at a super sensitive level, but macular pigments as well. We've really achieved more in the last 15 years in terms of our understanding, that we are now in a position where we really can make a safe recommendation for our patients. And I believe that not doing so at this point, as I said previous, is not using the evidence base that is now available. And as a scientist, it gives me great pleasure to do science that has an impact on what happens in the clinic setting. And I encourage all doctors to invest time in understanding this science a little more and to try and help patients, but to think so, as I said previous, outside of that of macular degeneration. These interventions are useful for all of our patients. So I would like to finish my lecture at this point and say that all of this information is available on my website, ProfessorJohnNolan.org and ProfessorNolan.com. These research papers are available. Our research centre, the Nutrition Research Centre Ireland, also has a website. That's the nrci.ie for Ireland. And if any of the listeners today would like to send me questions, I'd be happily answer them as part of this educational symposium, but also directly to try and give you the information that we need, because we have now information that should and can and will change and has changed, thankfully, what's happening in the clinic setting. And most importantly, the patients that we've worked with and the patients that we see across the world are really truly happy with this. We now have patients that have been on clinical trials and have stayed on the interventions approaching 6-7 years now. And thankfully these patients have not progressed in terms of their degeneration, and their vision has got remarkably better. And as I said in the early part of this lecture, we live in a world where there's more people. We live in a world where the elderly section of the population has become an ever-increasing proportion of the total population. We live in a world where there's more older people than young people. That's for the first time ever. And our job as scientists and as healthcare professionals is to use gold standard level 1 science to make recommendations to keep that elderly world happy and retain their functions, because we want to make sure that the functions of vision and cognitive and memory are enhanced in a way that we can all grow old together, happily and safely. Thank you very much. Gaurav Mila Mahagud.